Hi, it's my pleasure to be here today to speak about new antiretrovirals during pregnancy. These are my conflicts of interest. Now, it's pretty obvious that pregnancy involves a significant number of physiologic changes, including changes in GI motility and gastric pH, altered volumes, increases in blood flow and GFR, and altered activity of drug metabolizing enzymes. These changes can impact drug disposition. For instance, reduced concentrations of certain antiretrovirals have been observed in pregnancy. There are also changes which can affect drug exposures in the fetus and neonate, and which might potentially impact pregnancy or infant outcomes. So it is vitally important to have information on safety and efficacy of antiretroviral agents in pregnancy. Let's start with tenofovir alafenamide, or TAFT, which is not exactly a new drug, but until recently, there was insufficient data to recommend use in pregnancy. However, as of late 2021, TAFT is now a preferred reverse transcriptase inhibitor in pregnancy guidelines. An interesting difference is that the EACTS and BIVA guidelines recommend that TAFT not be used in the first trimester, while the DHHS guidelines do not have this restriction. The recommendation to wait until after 14 weeks before initiating TAFT is primarily based upon the IMPACT 2010 study published last year. This open-label randomized study compared dolutegravir plus either TAFT or TDF with emtricitabine versus efavirenz with TDF emtricitabine and enrolled women who were between 14 and 28 weeks of pregnancy. Those receiving dolutegravir had superior rates of virologic suppression at delivery compared to those receiving efavirenz, as shown in the graph on the left. Furthermore, a proportion of adverse pregnancy outcomes, including stillbirth, preterm delivery, and low birth weight, was observed in the dolutegravir plus TAFT group, as shown in the blue bars on this graph on the right, compared to the other treatment arms. In a further analysis, where more severe neonatal outcomes were weighted more heavily, dolutegravir TAFT was shown to provide the clearest risk-benefit profile, and both dolutegravir groups had a better risk-benefit profile compared to efavirenz. These study findings support TAFT as a preferred agent in pregnancy, but do not provide any insight on TAFT use earlier in the first trimester. What about TAFT pharmacokinetics? Two studies noted that TAFT concentrations were reduced by 33 to 50% in pregnancy compared to the postpartum period. Cobicistat can increase TAFT concentrations, but is not recommended in pregnancy. So the question is whether this reduction is clinically significant. If you look at the actual TAFT exposures, here expressed as area under the curve, or AUC, data from both studies show that all women had TAFT concentrations above the target threshold, implying that in the majority of cases, pregnancy-associated changes in TAFT exposures are not clinically relevant. With respect to safety, in this retrospective review of 100 women living with HIV who received TDF or TAFT during pregnancy, lower serum creatinine values with TAFT compared to TDF were observed in the third trimester. However, this difference was not significant in the final multivariate analysis, and no subject developed significant renal toxicity. Pregnancy leads to increased renal blood flow and GFR, which may help to reduce accumulation of tenofovir in the proximal tubules. So while TAFT is considered to have a safer renal profile compared to TDF, it is possible that this difference may not be as apparent in pregnancy. In addition to the latest update from the Tseng study, other registries and database studies have not shown an increase of neural tube defects with periconception exposure to dolutegravir, and it is now generally considered a preferred integrase inhibitor in pregnancy. What about other effects of dolutegravir exposure during pregnancy? At this year's CROI conference, the IMPACT 2010 study team presented a few papers looking at maternal and infant outcomes. In the study, women receiving dolutegravir had a higher rate of weight gain compared to those in the efavirenz arm, but this did not translate into significant differences in maternal hemoglobin A1C or maternal or infant glucose values. When looking at infant outcomes, those exposed to efavirenz were significantly more likely to be underweight at 1 year, as shown on the right in purple, with 11% of efavirenz-exposed infants being underweight compared to 3 to 6% of dolutegravir-exposed infants. There was no difference in infant obesity between the treatment arms. Currently, there is still insufficient data to recommend the use of bictegravir in pregnancy. The antiretroviral pregnancy registry includes 202 pregnancies with bictegravir, the majority with periconception exposures and no reports of neural tube defects. There are 4 cases of bictegravir use in pregnancy published in the literature. In the first case by Lee et al., bictegravir was started at 29 weeks in a woman previously non-adherent with a viral load of 4 logs. Her viral load was undetectable after 28 days of treatment and at delivery. The other 3 women were virally suppressed and either already on bictegravir or switched during the first trimester. In all cases, maternal viral load was undetectable at delivery and all infants were negative via HIV DNA PCR. In 2 pregnant women, bictegravir area under the curve was 35% lower and bictegravir C-trough was 49% lower in the 3rd trimester compared to the postpartum period. The bictegravir trough concentrations were similar to those seen with twice-daily bictegravir administered with rifampin, which is a contraindicated combination. The clinical relevance of these changes is unclear, as all bictegravir concentrations remained above the protein-adjusted IC95. Clinically, high fetal-maternal ratios of bictegravir have been observed, suggesting high placental transfer. Interestingly, bictegravir concentrations in 1 infant showed almost no change over the first 3 days after birth, likely reflecting immature CYP3A4 and UGT1A1 functioning. This raises the interesting question of whether in utero exposure to bictegravir could also serve as HIV prophylaxis in the neonate. Cabotegravir is specifically not recommended for use in pregnancy due to insufficient data. We already know that pregnancy-induced physiologic changes can impact total exposures of many drugs, particularly in the 3rd trimester. And it is unclear whether pregnancy-related changes in body fat and BMI could impact the kinetics of intramuscular long-acting agents. The DHHS guidelines state that women who become pregnant while virally suppressed on long-acting cabotegravir rilpivirine should be switched to an oral 3-drug regimen. This is a much more conservative approach than the usual suggestion of continuing current ART with close monitoring. There are data on 26 women who became pregnant while on long-acting cabotegravir rilpivirine through studies or compassionate access programs. After confirmation of pregnancy, participants were switched to an alternative oral antiretroviral regimen. There were 11 live births, 8 elective abortions, 7 spontaneous abortions, and no stillbirths. The majority of infants were born at term with normal birth weight and no congenital anomalies. 1 infant was born preterm with congenital ptosis to a woman with multiple maternal risk factors and who had previously experienced a spontaneous abortion at 23 weeks. There are also some data of long-acting cabotegravir alone in pregnancy from the HPTN 084 PrEP study. During the blinded phase, there were 49 confirmed pregnancies, 29 in the cabotegravir arm and 20 in the TDF emtricitabine group. Upon pregnancy confirmation, participants were switched to open-label TDF emtricitabine, and no congenital anomalies were reported. What happens with cabotegravir and rilpivirine concentrations in pregnancy? Data are available from 7 women who discontinued long-acting cabotegravir rilpivirine after becoming pregnant and who had quarterly PK sampling for 52 weeks after their last injections. In these women, cabotegravir and rilpivirine PK tails were within the range observed in non-pregnant women. In the HPTN 084 PrEP study, cabotegravir terminal half-lives in pregnant women were similar to historical data in non-pregnant women. Now, it's important to note that these data describe the pharmacokinetics in women who discontinued long-acting therapy after becoming pregnant, but it does not provide information on what happens when long-acting cabotegravir rilpivirine is continued during pregnancy. So I was happy to see this PBPK model presented at this year's CROI conference, which suggests that the pharmacokinetics of long-acting cabotegravir administered throughout pregnancy are similar to those in non-pregnant adults. These data are reassuring, and similar information for long-acting rilpivirine is also needed. There are insufficient data to recommend the use of doravirine in pregnancy. Placental transfer has been noted in an ex vivo model, and there's currently one study underway to examine the pharmacokinetics of doravirine in pregnancy. The antiretroviral pregnancy registry has extremely limited information, with one defect out of 5 live births with first trimester exposure, but no further details, and just 1 live birth with later pregnancy exposure. 14 pregnancies have been reported in the FCSHP clinical development program, including the BRIGHT study, phase 2b, and phase 1 studies. There were 8 pregnancies with fostemsavir exposure and 1 in the partner of a male study participant. All pregnancies included first trimester exposure, and 2 women continued fostemsavir throughout pregnancy. There were 5 live births and no congenital anomalies reported. Now, keep in mind that there's already quite a lot of experience in pregnancy with the individual drugs in oral 2-drug regimens, including safety. So you wouldn't expect any new signal or increased toxicity risk with using fewer rather than more drugs. There have been 12 pregnancies reported in the dolutegravir lamivudine clinical development program. Participants were withdrawn from study and either discontinued or modified treatment to a 3-drug regimen upon pregnancy confirmation. So far, there have been 3 live births and 1 continuing pregnancy, with no congenital anomalies reported. However, there are no data on the virologic efficacy of 2-drug oral regimens in pregnancy. There is one currently enrolling study for initiation of dolutegravir lamivudine in antiretroviral naive pregnant women between 14 and 28 weeks gestation and viral load over 1,000 copies. So this will provide important information on the efficacy of dolutegravir lamivudine in preventing perinatal transmission. Data on dolutegravir rilpivirine in pregnancy is also quite limited. Rilpivirine concentrations are reduced by about 30% in pregnancy, and there are food and gastric pH considerations. More frequent viral load monitoring is recommended with rilpivirine 3-drug regimens during pregnancy. And similarly, the DHHS recommends more frequent viral load monitoring in virally suppressed women who become pregnant while on any oral 2-drug regimen. Not surprisingly, pregnancy information is lacking for investigational agents such as lenacapavir and islatravir. This highlights the need for purposeful research of new antiretrovirals in pregnancy in pregnant and lactating women, and intentional incorporation of such studies in multiple stages of drug development, as outlined in the suggested framework by Eek et al. For lenacapavir, pregnant or lactating women will be included or allowed to remain in PrEP studies, which is great to hear. Finally, looking to the future, one very exciting innovation to keep your eyes on is the development of multi-purpose technologies, or MPTs, which can combine different therapeutic agents in oral, parenteral, and vaginal dosage forms to simultaneously prevent HIV, pregnancy, and STIs. This year's CROI conference included a number of presentations on early work with MPTs to prevent HIV in pregnancy, including subcutaneous injections, implants, and intravaginal rings. This is expected to be a very active area of ongoing research, which is really wonderful in terms of offering more choices to women in the future. With that, I'll thank you for your attention and look forward to questions and discussions following. Thank you.